Okay, sir. 53-year-old male, electric contractor with known case of bronchial asthma with the chief complaints of altered sensorium and vomiting, sir.
Possibilities?
Altered sensorium and vomiting, a possibility of meningitis is maybe there, sir. Also, can be electrolyte abnormalities can also resulting in this altered sensorium, sir. Or can be altered sensorium vomiting. It can be cerebrovascular accident, sir. ICH or
Okay. It can be tumor, it can be infection.
Yes, a tumor infection, sir.
It can be metabolic.
Metabolic also there.
Renal failure.
Renal failure can also present. Yes, sir. Uremic encephalopathy can present.
Okay, present. So options are many.
Yes, sir. History of presenting illness. At around 7 p.m. on 11/4/2022, patient bystanders noticed that the patient is agitated.
Not the date, 11/4. Okay.
Yes, sir. Around 7 p.m., the attendants noted the patient was agitated, increased pacing across room, scratching of head, shaking movements of hands, rigidity of entire body, staring look, excessive sweating, no history of colonic movements, uprolling of eyes.
It is colonic, not colonic. Sorry for that.
Okay, sir. Okay. History of colonic movements, uprolling of eyes, frothing from mouth, ictal cry, involuntary maturation and defecation, sir.
So,
sir, can be with excessive sweating, staring look, rigidity of entire body. It can be rabies. Can also be a presentation. No?
So, can it be something like a delirium?
Yes, sir. Encephalitis like present. Viral encephalitis. Lasted for 10 minutes. Brought to the emergency department. One episode of vomiting, non-projectile, followed by loss of consciousness, sir. No history of headache, fever, paresthesia, tremor, abdominal pain, chest pain, palpitation, or hematemesis. Sir, past history.
Anything else you would like to comment on now?
No, sir.
Non-projectile.
Non-projectile vomiting, sir. Past history of bronchial asthma diagnosed at the age of 15 years, exacerbation during winter season and when exposed to dust on inhaler. System hypertension for 1 year. History of one episode of altered sensorium with uprolling of eyes followed by loss of consciousness in December 2021. Managing emergency department sent home records not available. COVID-19 infection in December 2022. Category B at home. Admitted at hospital for 1 week in January 2022 with complaints of lethargy. Admitted at hospital second time for the April 2022 for evaluation of lethargy and discharged and was advised to consult psychiatrist. Consulted psychiatrist at hospital on 9/4/2022 and was prescribed medications.
So, sequence of events, you see, he's in the hospital on 2nd of April.
Yes,
then
sir.
He's on hospital is 4th of April. Then
yes, sir.
He's going to hospital number 3.
Yes, sir.
Or 9.
Yes, sir.
Okay, where he was prescribed medications.
Yes, sir.
So these dates and sequence are very short.
Yes, sir.
In few days everything is happening.
Yes, sir. Their non-veg diet, decreased appetite, normal sleep, regular bowel and bladder habits, no addictions, health anxious, completely devoid of salt since hypertension diagnosed, regularly visit doctors and do blood investigation by self-prescription.
What do you make out now?
Sir,
he is not taking salt at all, you know.
Yes, sir. Okay, sir. Oh, sir, hyponatremia.
Possibility, okay.
Yes, sir, possibility, sir. Treatment history, patient is on telmisartan, hydrochlorothiazide, paroxetine, clonazepam, sir.
So, this patient was on psychiatric medications.
Yes, sir, SSRIs and
9/4, and he's coming on 11th with his complaints.
Yes, sir.
So what do you make out?
Sir,
In spite of treatment, he did not improve, rather he deteriorated.
deteriorated, sir.
So what do you think?
Sir, on general physical examination, patient was drowsy, E2V2M6, no pallor, icterus, cyanosis, clubbing, lymphadenopathy or edema, skin, hair, nails and thyroid normal, pulse 68 per minute, BP 120/80, respiratory rate of 14, temperature of 96 degree Fahrenheit. Hair mental function, patient was drowsy, GCS of E2V2M6, cranial 346, bilateral pupil 4 mm in size, round and regular margin, direct and consensual reflex positive, slow, horizontal clonus present.
Where
Motor
is the
system.
clonus? Where is the clonus? In the eye.
Yes, sir. No horizontal clonus in the eye, sir.
Okay, right.
Okay, sir. Motor system examination. Upper limb tone was normal. Lower limb was rigid. Reflexes. Abdominal reflex were present on both sides. Plantar were extensor. Biceps, triceps, and supinator were brisk, and knee jerk was exaggerated.
Yes.
With CVS S1 S2 heard and respiratory system bilateral LMD equal. Normal vesicular breath sounds. Per abdomen soft, non-tender, no organomegaly, bowel sounds present.
Any points to be noted here?
The reflexes are being brisk, sir.
Okay.
With the bilateral plantar extensor.
Yes. Plantar extensor can be non-specific, no?
Yes, sir. Can be non-specific, sir.
What we say about his rigidity?
Lower limb rigidity, sir. Maybe not sure, sir.
What's the provisional diagnosis can you make now?
Sir, metabolic encephalopathy, sir.
Right.
Possibility due to hyponatremia, sir.
Okay. So,
Serotonin syndrome, sir. This was
he has got late onset seizure
with
the history of psychiatric medications within.
yes, sir.
After starting the drugs, he went into problem, no?
Yes, sir. Yes, sir.
And low horizontal clonus of the eyes.
Yes, sir.
The rigidity of the limbs.
Yes, sir.
No?
Yes, sir. Yes, sir.
Can it be neuroleptic malignant syndrome?
It can present, sir.
Okay. So investigations, basically not much except that
Total count
is normal, sodium
yes, sir.
low, potassium 3.2, spot sodium is 56.
Okay, sir. CT brain, no significant abnormality detected. Clinical interpretation, this record shows evidence for a mild diffuse non-specific disturbance of cerebral function. Showed background activity 8 Hz in posterior head region which are symmetrical in distribution. There were persistent diffuse excess beta activity. Hyperventilation, 40 stimulation were not performed. Sleep record could not be obtained. Serotonin, DDs of serotonin syndrome, neuroleptic malignant syndrome, hyponatremia.
Okay. So how do you treat serotonin syndrome?
Not sure, sir.
What are the drugs acting on serotonin, by the by? SSRI?
SSRI, sir.
Any other drug?
SNRI, sir.
Okay, any other? What is cyproheptadine?
Anti-appetite. Sure. Antihistamine, sir.
Yes, it's given for migraine, no?
Yes, sir. Yes, sir.
That is said to be the antidote.
Okay, sir. Okay, sir.
And the patient was started on that, and then his symptoms improved.
Sir. Yes, sir.
Of course, he has received a saline and all.
Okay, sir.
So, what is serotonin syndrome?
Overdose of a serotonergic agent or after initiation of a single serotonergic drug, or maybe interaction between different serotonergic drugs and drug interaction with net effect of increased serotonin level may lead to renal dysfunctions.
So there are different drugs which interact and produce, and mechanism is inhibit serotonin uptake, inhibit serotonin metabolism, increase serotonin synthesis, increase serotonin
release,
activate
serotonin receptors,
cyclic
CYP415.
Okay, autosomal oxidase. So anything can produce excess amount of serotonin, which can produce the serotonin syndrome.
Yes.
It's a treatable emergency.
Yes,
and both differential diagnosis will be neuroleptic malign syndrome.
Okay, sir.
So, there are different classes of drugs implicated.
MAO
inhibitors,
SSRIs, SNRIs, opiates, cold remedies, atypical antipsychotics, and some antibiotics like linezolid plus SRI combination, fluconazole, ciprofloxacin.
So what are the components of this syndrome?
Components includes altered mental status, neuromuscular abnormalities, and autonomic hyperactivity.
Okay. So some of the symptoms and signs this patient exhibited was including vomiting.
Yes, sir.
Coolness, rigidity.
Yes, sir.
Everything was possible. Anxiety, agitation, disorientation. He was walking around, running around, restlessness, excitement, tremor, everything. So there are criteria. What are they?
Sternberg's criteria showing 3 or more of the following: mental status changes as confusion, hypomania, and restlessness, agitation, myoclonus, hyperreflexia, diaphoresis, shivering, tremor, diarrhea, incoordination, fever.
What are the things presented in our case?
Mental status changes was there, agitation was there, hyperreflexia was there, and diaphoresis was there, sir.
So we had enough. The other criteria is also
Hunter's criteria with any one of the following: spontaneous clonus, inducible clonus with agitation or diaphoresis, ocular clonus plus agitation or diaphoresis.
So our patient had ocular clonus plus
agitation and diaphoresis was there.
Agitation. Okay. So how do you apply this criteria? Looking at the people on serotonin medication.
If there is clonus, there is spontaneous clonus, it meets the criteria for serotonergic syndrome. And if there is no spontaneous, and if it is inducible clonus, whether its agitation is present or diaphoresis is present or hypertonia plus fever present, it can fit onto the criteria. There is no clonus, but there is tremor plus hyperreflexia can also present fit onto the syndrome, sir.
So since there is a treatment, the essential to recognize it. Okay, and based upon symptoms, you can call it mild, moderate, and severe. So what will be close differential diagnosis in this patient?
Neuroleptic malignant syndrome, sir.
Yes, what else? Can be hyponatremia.
Hyponatremia is there, sir.
But
seizure can.
In hyponatremia, does it produce hyperreflexia?
No, sir.
Diaphoresis?
No, sir. Ocular clonus will all. No, sir.
So what about seizure? Can it produce mental changes?
Yes, sir. And hyperreflexia can also be there, sir.
Also produce, but not ocular clonus and diaphoresis. What about neuroleptic malignant syndrome?
Mental changes will be there, sir, and the sweating, profuse sweating will be there, sir. Diaphoresis will be there, sir.
And what about reflexes?
Reflexes will be normal, sir.
That's right. That's one important point that reflexes will be normal and ocular clonus will not be present. More than that, neuroleptic malignant syndrome comes many days after the starting of the treatment.
Of the anti-epileptics,
psychotics. Soon after the initiation of the treatment.
Yes, sir.
And the prognosis is very good.
Yes.
For both the conditions, provided you diagnose it. And what happened to TPK?
Will be high, sir.
It will be high. So in our patient, TPK was also?
It was 192. It was normal, sir.
Okay. So, how many cases of serotonin syndrome have you seen?
No, sir, I haven't seen, sir.
Possibly there will be cases, because you are using so many drugs. Possibly they are going back to the psychiatric ward or to be there. And worth
Okay, sir.
considering it's a differential diagnosis of neuroleptic syndrome. And
Okay.
hypernatremia and the seizure all came as a close differential
Okay.
diagnosis. So these are the three cases we have for today, and all of them
Okay, sir.
came with abnormal behavior,
Okay,
no?
sir.
These are like
Yes, sir.
altered sensorium, and all
Yes, sir.
different patterns and very rare scenarios.
Okay, sir.
So do you have any doubt, Vishnu?
Sir, this cyproheptide heptide in how many days we have to give, or a single dose is enough, sir?
No, we gave for 3 days if I remember correctly. 4
Okay,
milligram
sir.
tablets are available.
Okay, sir. Okay, sir.
Easily reversible.
Okay, sir. Okay, sir.
On the one
Actually, I
hand,
have.
we have medications by psychiatrists.
Okay.
Other hand, we have
Okay.
corrected the sodium, and in between, this drug was also given.
Okay, sir. Okay, sir.
The issue is we don't have much investigation to prove or disprove.
Yes, sir. Yes, sir.
It's the history that is important. Drug history must be taken always.
Yes, sir. Yes, sir.
Drug history will give the clue, and the temporal profile. When was this drug started, and what is
Ninth.
the date of onset
Yes,
of
sir.
the illness?
Yes, sir. 9th it was started and illness was 11th, sir.
That's it. So,
2 days.
the importance of taking details of history is important in neurology and psychiatry. You may get the diagnosis from there itself.
Okay, sir.
But if you miss the names of the drugs and so on,
Okay,
you
sir.
may not get the diagnosis.
Okay, sir.